Now let's go to the calculation of the volume of the bladder. And of course, for calculating volume, we need 3 parameters, A, B, and C. That means 3 different diameters. How do we get them? We measure the ventrodorsal and the transverse diameter of the bladder in a transverse plane, and then we turn our transducer into the longitudinal scan plane and get our 3rd diameter, the craniocaudal distance. We will show this to you afterwards. But then we've got our 3 measurements and can calculate the volume of the urinary bladder with this formula over here. A multiplied by B multiplied by C and divided by 2. Many ultrasound machines have their own volume calculation program, but still some don't, and I think in any way it is very helpful to be able to calculate the bladder volume for yourself. So we need 3 diameters. I again start with a transverse suprapubic view, place my transducer at the lower abdomen, feel behind the pubic bone, look for a mark which is pointing towards me, get a good picture of the urinary bladder. In the center of the monitor picture, press the freeze button, and now I can take my measurements. We got the transverse diameter from the right to the left side of the patient, which is 10 centimeters here. Sorry, take it again. And the second diameter is the ventrodorsal one, over here, which is 4.5 centimeters. We store that. And then we need a 3rd diameter. So we have to turn our transducer again into the longitudinal view. We stay at the lower abdomen, turn clockwise around 90 degrees, tilt our transducer again behind the pubic bone. Our mark is pointing to the head of the patient. Press the freeze button. And now we need the craniocaudal diameter from the top of the bladder to the bottom. It's about here. Which is 90 millimeters. So now that we got our 3 diameters, we can calculate the volume. We remember the formula is A multiplied by B multiplied by C divided by 2. So we take our first diameter, A, which is 10 centimeters, multiplied by 4.5 centimeters, which was diameter B, multiplied by 9 centimeters. This is 405 milliliters, and this divided by 2 is about 200 milliliters, which is a normal volume for a filled urinary bladder. The next thing I want to show to you is what an empty urinary bladder looks like. Why is this important? You should be able to recognize an empty urinary bladder in the lower abdomen. And when you're looking for residual urine, you have to be able to assess if the urinary bladder is empty or filled. So you will see this is not so easy at the beginning, but I will show you how to do. Again, we place the transducer at the lower abdomen into the transverse suprapubic view. The mark of the transducer is pointing to our side. And as you can see, I have to tilt the transducer strongly towards the foot end of the patient. And here we can see the urinary bladder. I show you this small structure over here with nearly no fluid in it. And you can easily understand why it's not possible to assess the wall of the urinary bladder because it's folded, it's thick, and you can't distinguish if there's a tumor or polyp or not. Again, I want to show you again how much I have to tilt the transducer behind the pubic bone because this is important to succeed in finding the empty urinary bladder. Look how much I have to tilt, and only now I'm able to find this organ over here. Here, the urinary bladder, when nearly empty, in a transverse suprapubic view. I try this again in the longitudinal view. Remember the mark pointing to the patient's head. Shortly above the pubic bone, and tilt the transducer behind the pubic bone. And I must admit it's not so easy this time. But here we can see this small space over here, the border of the urinary bladder, and here the content of it, the fluid. It's better seen over here now. What I did now is that I was tilting the transducer, sweeping it to the left and to the right a little bit. Here again, an empty urinary bladder in a longitudinal plane. In this chapter, we will introduce to you some of the most common pathologies of the urinary bladder we possibly encounter in everyday routine. We start with urinary retention. Urinary retention is easily detected in its acute and painful form, but there's also a chronic form, which often shows no or just slight symptoms. As for the causes of urinary retention, an obstruction of the urethra is a frequent reason. The underlying disorder can be, for example, benign prostate hyperplasia, which is common in elderly male patients. Other causes can be concrements in the urinary bladder itself or in the urethra. Strictures of the urethra or malignant diseases of the bladder that block the urine flow can be additional causes for urinary retention. Other reasons can be a dissensus of the uterus, certain medicaments, for example, anticholinergic medication, and also various neurologic disorders. Inflammations of the prostate can also cause urinary retention, and a wrong positioned urinary catheter is a cause we should always have in our mind, especially when a patient with catheter complains about abdominal pain and when his urine flow is ceasing. Patients with acute urinary retention present with anuria and lower abdominal pain and discomfort. Also, oliguria with urge can be a symptom that means the bladder is not emptying. Just small amounts of urine can flow out of the bladder. The patient can show a so-called overflow incontinence, where the bladder is so full that the patients have no influence about urine dripping. The patients can also show vegetative symptoms like cold perspiration, hypertension, and even bradycardia. When urinary retention is not detected and treated, it can lead to further accumulation of urine in the upper urinary tract and also cause hydronephrosis. In severe cases, even a rupture of the bladder can occur. Longer-standing urinary retention can lead to recurrent infection and also to renal failure when there's chronic urinary retention and hydronephrosis. So how can we detect urinary retention in ultrasound? You will see this is quite an easy matter. Either we find abnormal amounts of fluid in the bladder. I remember a patient with urinary retention where one of my colleagues performed an ultrasound scan, and at the first look he thought that the patient had ascites because the bladder extended far into the abdomen. But we can find a normal urinary bladder filling, but the patient has no urge to void. When I see a really full bladder in my routine scan, I always ask my patient if he or she already has an urge and scan the bladder again after the patient has been urinating. In patients with urinary retention, we always should take a look at the kidneys to see if there's possible hydronephrosis present. When urinary retention is the cause for hydronephrosis, it usually shows up on both sides. So here, let's see a picture. We got the urinary bladder over here, filled with urine, and it's really, really full. It's a large amount of fluid in it. It was about, I remember, 500 or 600 milliliters. And the patient did not really have an urge to void. And he also complained about lower abdominal pain. And of course, the problem of the patient had to be solved and he needed a urinary catheter. To detect and measure residual urine is quite an easy matter also and helps a lot in early detection of urine disorders. Residual urine is defined as amount of fluid that remains in the bladder after urinating. An amount up to 50 milliliters is normal. Amounts of 100 milliliters or more show a urinary disorder for sure. And amounts between 50 and 100 milliliters are some kind of a gray zone. Further observation is indicated. Important for this examination is that the patient, in this case, has urinated shortly before the scan. Sometimes in clinical routine the patients have to wait for some time, and when they drink in the meantime there's the possibility of newly produced urine already. So it is helpful to ask your patient if he or she has urinated shortly before the examination. The next chapter will be tumors of the urinary bladder. Ultrasounds can help detecting pathologic changes of the urinary bladder wall when the preconditions are good and the bladder is reasonably filled. When we find any tumor of the bladder, further investigation is needed anyway. But there are a few differential diagnoses we can exclude during our ultrasound examination. Sometimes clotted blood in the bladder or a bladder stone can look like a tumor. So what can we do for differentiation? This is quite an easy matter. We turn our patient to one side and keep our ultrasound beam on the object of interest. When the structure is staying at its place, it's most likely a tumor. When it is moving, clotted blood or a stone is more probable. In any case, even if it's not a tumor but bleeding or urinary tract stone, the cause for this condition has to be found, of course, and the problem has to be solved, so the patient has to see the urologist. Let's see now a video clip. And again, I want you to take a look at it for yourself first. So take a look at the corner, the right corner here of the bladder. Yes, this is a small object. I stop the video over here. This round small object in the corner over here is likely to be a bladder tumor. And when we turned the patient to his side, the structure stayed at the same place. So it means it was attached to the wall and most probably a urinary bladder tumor. And so we sent the patient to the urologist where there was further investigation and they found, in this case, a malignant tumor of the patient, but in an early stage because we already detected it in our ultrasound examination. In this chapter we learned about the anatomic features of the bladder, how to image the organ in two different planes, how to calculate the volume, and we also became acquainted with some of the most common pathologies of the urinary bladder.